ventilatory status, and indirectly circulatory and metabolic status. So by using this one thing, you get access to a lot of information that you can use, help dictate, where you want to go with your patient. A couple definitions. Capnography is the measurement of carbon dioxide in the exhaled breath. Capnometer is the numeric measurement of CO2, and capnogram is the waveform. End-tidal CO2, EtCO2 or PEtCO2 is the level of or partial pressure of carbon dioxide release at end of expiration. The difference in oxygenation versus ventilation. Oxygenation is how we get oxygen to the tissue. Oxygen is inhaled into the lungs where gas exchange occurs at the capillary alveolar membrane. Oxygen is transported to the tissues through the bloodstream. Pulse ox measures the oxygenation, the saturation of oxygen in the blood. Ventilation is the movement of air. It's how we get rid of carbon dioxide. Carbon dioxide is carried back through the blood, exhaled by the lungs to the alveoli. Capnography measures the ventilation. Your capnography versus your pulse ox. Capnography provides an immediate picture of the patient condition. Pulse ox is delayed. Capnography will show immediate apnea, while pulse ox will show a high saturation for several minutes. A good way to test this, if you have the probe on your finger, you're reading whatever your number's at, you hold your breath, chances are you'll have to breathe again before you even see your numbers drop. So it's not immediate, where if you have the capnography on, it'll show when the patient stops breathing. It's more immediate. Circulation and metabolism. Capnography indirectly measures metabolism and circulation. By doing so, you have the increased metabolism will increase the production of carbon dioxide, increasing your EtCO2. A decrease in cardiac output will lower the delivery of carbon dioxide to the lungs, decreasing the EtCO2. Ray Fowler put it as, CO2 is the smoke from the flames of metabolism. Your normal capnography values, EtCO2, anywhere from 35 to 45 millimeters of mercury is considered normal. They had a nice caution listed on the website I pulled this from, because we carry the nasal cannula capnography tools. Imperfect positioning of the nasal cannula capno filter may cause distorted readings. Unique nasal anatomy, obstructive nares, and mouth breathers may also skew your results and or require repositioning of the cannula. Also, oxygen by mass may lower the reading by 10% or more. So if you have it on a patient, look at your patient condition in coordination with your results and your numbers. If it seems off or something seems, like it's not matching up, reposition the nasal cannula. It could be affected by what you see here. This is a picture of your waveform capnography, but you need to know exactly what you're looking at, so this kind of breaks it down. From A to B, starting from left to going to right, A to B is post-inspirational, your dead space exhalation. B is the start of alveolar exhalation. B to C is the exhalation upstroke, where your dead space gas mixes with your lung gas. From C to D is the continuation of exhalation. D is the end-tidal value, which is the peak of concentration. And from D to E is the inspirational washout. So sometimes it gets confusing, but your waveform is only when the person's breathing off. It's not the other way around. You have abnormal values and waveforms. EtCO2 less than 35 is indicative of hyperventilation or hypocapnia, where an EtCO2 greater than 45 could be related to hypoventilation or hypercapnia. Four main abnormal waveforms that we can come across: hyperventilation, hypoventilation, esophageal intubation, and obstructive airway with your shark fin. If you have esophageal intubation, you're not going to have anything. It'll be a flat line because you're not getting any carbon dioxide. And obstructive airway, indicative of asthma. Everything's constricted down, so it's going to have very much looks like a shark fin. It'll be more sloped instead of the big blocks. I got this from this blog on emscapnography.blogspot.com. This was a very brief amount of the information that they have there, so if you get a chance, you can check it out. They have a lot of information.
Very good.
Thank you.
I have a lecture on this, but it's like 180 slides. So
yeah, there's a ton of information on
it has a lot of
capnography.
examples of waveforms that you can practice on and whatnot. You understand that the ERs, most of the nurses in the ER don't know what you're talking about when you say this. They don't know what capnography is. They don't even hook it up unless recently they started. But even where I am, they don't use it. EMS comes into the system, they have them on a cap, they have a cap on them and have them on capnography. Explain what it is. They're monitoring and reading stuff out of it.
It's all you, man.
All right. Hey guys. Firefighter Daniel Plattis here. Yes, sir. I did.
We want to go on a urine break. This will take a little bit.
Yeah. If you go to the restroom.
Urine break.
I'm doing my presentation on shock. How do I? What button do I hit?
Go up towards the slideshow. Go to the top where it says slideshow.
Or that one.
Oh gosh, what'd you do? Oh, there you go. Good job, Coots. All right. Somebody, should I wait for?
Nah,
Okay.
they're lost.
Mark doesn't understand anyways.
All right.
Make sure we test them on what he misses.
Like I said, doing my presentation on shock. All right. What I'm going over. What is shock? Types of shock. Compensated, decompensated versus irreversible. What is shock? Shock is a medical emergency in which the organs and tissues of the body are not receiving adequate flow of blood. This deprives the organs and tissues of oxygen, allows buildup of waste products. Shock can result in serious damage or even death. Hypovolemic shock. This is shock due to insufficient blood volume, either from hemorrhage or other loss of fluid, or from widespread vasodilation that normal blood volume cannot maintain tissue perfusion with. You replace 3 liters of fluid for every one lost. Burn patients in shock usually have this shock due to the evaporation of fluids. Cardiogenic shock is also known as a pump problem. This is a shock resulting from inadequate cardiac function, as from myocardial infarction or mechanical obstruction. Characteristics include hypovolemia, hypotension, cold skin, weak pulse, and confusion. Neurogenic shock is caused by the loss of nervous control of peripheral vessels, resulting in an increase in the vascular capacity. Onset is usually sudden, but is quickly reversible if the cause is removed and treatment is instituted immediately. The patient will present with normal pulse pressure and low BP. Septic shock is a medical condition as a result of severe infection, though the microbe may be systemic or localized to a particular site. It can cause multiple organ dysfunction syndrome, formerly known as multiple organ failure, and death. Its most common victims are children and elderly, as their immune systems cannot deal with the infection as effectively as those of healthy adults. Double period. Frequently, patients suffering from septic shock are cared for in intensive care units. Distributive shock. Make my eye contact. Distributive shock is defined as hypotension and generalized tissue hypoxia. This is a form of relative hypovolemia and is a result of blood vessel dilation. Septic shock is a major cause of distributive shock. Insulin shock. Hypoglycemic reaction to overdose of insulin, a skipped meal or strenuous exercise in an insulin-dependent diabetic. Should have been period. Characteristics include tremors, dizziness, cool, moist skin, hunger, and tachycardia. Another period. Sometimes progresses to coma and convulsions. This is a patient compensating in shock. It's tachycardia with strong distal pulses, increased respirations, EtCO2 normal between 35 and 45, nausea, vomiting, thirst, skin cool and moist, normal blood pressure, tachypnea, hyperpnea. Fast breathing. Jesse. Patient moving from compensated to decompensated. Tachycardia with weak distal pulses, feeling of impending doom, increase or decrease in EtCO2. Skin is pale, cold, and wet. Local cyanosis. Tachypnea with decreased tidal volume. Decompensated. Blood pressure drops, weak, rapid carotid pulses with absent distal pulses, profound hypoventilation, global cyanosis. Irreversible, death is inevitable. I got all my information from the Firelex Medical Dictionary. Done. Thank you. Thank you. Tried to hurry through that.
What I'd like to do is start a PowerPoint bank, presentation bank of everybody's presentations and puts them up as PowerPoints. So that way they can always go in and look at something at some point.
We have a training drive, we'll put them on the training drive.
So we could have a general bank that everybody puts their PowerPoints into, emails into, or however it works. I think that would really be beneficial.
Okay.
Okay? All right, you guys can take a break for a few minutes.
Hello. How's that? Okay. So let's just run through some neurologic emergency stuff here. I know that you see more and more of this. Probably not this time of year, but they've changed some of the parameters for stroke alert and whatnot. So, I don't know if my changer works. I replaced the battery, but it hasn't been changing the slide, so I may have to sit here to do it. Yeah, let me see how far I can go with this. Nah, I need to move around. Okay, so I want to mention this because the college, whatever it's going to be called, Edison State, Southwestern State, is going to be implementing the National Registry certification standards. So as a standard competency evaluation for their medics in their training program. So this is something important. It standardizes what everybody's taught and what they learn. It also gives the program some national validity. So these are changes that are occurring as we speak with the program at Edison. In addition, we're really after critical thinking skills that we want to impart to the students to be able to function in the street as opposed to a cookbook of how to treat a heart attack. So is it going to be a change from what's been traditionally taught? Yes.
I heard that we might be moving to the National Registry.
Don't know. Nobody's talked to me about it.
No, we're not as far as we're concerned.
Okay, so.
Not to go back to what you mentioned before, those innovations you were talking about before, are we gonna try to get?
I have to see. I have some work coming up at Gulf Coast, a short contract. I'll see who I can.
Because it's mainly the hospital.
Yeah, the hospitals are the problem because they have now they're going to have medical students or residents too, so they're going to take time. But they have paramedic students, they have PA students, they have nurse anesthetist students. There's not enough people to train. That's the problem. There's too many people that want training, and there's not enough patient volume. And yeah, plus you deal, and I've had this problem with some of the people I know who come to me and say, hey, I need a rotation in OBGYN, for instance. And I can't get one. And you know, and I didn't know this until recently, but there's a lot of training programs for PAs and nurse practitioners where you are responsible as the student to get all your clinical rotations. There is no preset, oh, I'm gonna go here for OB, I'm gonna go there for peds. It's all in your lap. So you gotta go make the arrangements to have these rotations to be able to graduate the program. And what happens is, like I said here, and this is from a student from Tampa who came to me and said, I can't get in anywhere. She said, all these programs are full. She said they have other programs that use them, and I can't get these rotations that I need. So I made an arrangement for her to have one of her rotations here. But the problem you run into is that you get physicians, because it has to be with a doctor, whether you're a PA or a nurse practitioner student, you get physicians that don't want to do it, don't want to teach, don't want to be bothered. And when I was at Cape, the attitude amongst my partners there, when it came to having osteopathic medical students in the department to train them, was we don't want to be bothered with it. To them, it was a bother. For some reason, you know, the old feeling of, you know what, I had active guys in practice train me when I was a student, you know, and a resident, people that practiced, they took the time out to train me. So I therefore have to give back to my profession because they gave to me with the understanding that I would do the same in the future. However, you have an attitude now coming out for the last 30 or 40 years, well, probably 25 years, because I've been out 40, almost 40, that everybody's out for themselves. No, I don't want to train any students, I'm too busy. Or I don't have time for that, or maybe they're just afraid that the student's going to ask them a question that they can't answer, or the student's going to say, why did you do that? You know, I learned you're not supposed to do that in that situation with that patient. Maybe that's what they're afraid of. I don't know. But the point is that that idea of passing on your knowledge and your skills to somebody else apparently is not in vogue anymore and is not done very often. So if there's anything I can impress upon you with this idea of these tiered paramedics being more experienced and having more skills is take the time. Those of you that have more experience and knowledge because you've been doing it longer, take the time to teach the younger guys. I mean, it's your responsibility. It makes the whole agency better. You know, it just makes it better. Like my daughter had said to my wife last week about the code. You know, that I always tell you, you have to set the tone in these calls that you get. You're the person they look up to. I was at a funeral, a nurse's son drowned in the Cape. I knew the nurse. A lot of people from the ER were there. A kid, it was a Jewish ceremony. So there's a big hole, boxes in the hole, and they throw dirt on top of the box. A kid, I think he may have been a cousin to the child that died, was standing there looking in the whole time the rabbi was saying the prayers. And what do you think happened to the kid? He fainted. And they're screaming for a doctor for this, and I'm looking around because this always happens to me for some strange reason. Whether it's an airplane, a train, you wouldn't believe the stuff that's happening. So I'm looking around thinking, I don't believe this. Next to me is a paramedic, two paramedics from the beach in their uniforms, and then over behind where the nurse was, because she was in the front with the rabbi, was everybody from the Cape ER, several doctors, nurses. So I was with Tori Vagel and Jake Lamb, and I turned and said, come on, we have to go over here. And we walked over. Do you know, they didn't acknowledge me. They didn't acknowledge Tori because he had his coat on. They acknowledged Jake because he had a patch that said paramedic. So I just backed away from it and left it. I mean, the kid was awake. He was a little pale, but he was fine. And it was just funny, and I started thinking about it, thinking, this is what I always say, is that these people, they see something like that, and that's what they're going to key on, you know, and they're going to say, oh, thank God, a paramedic, because that's how the perception is. And that's why you have that responsibility. You have to be professional. Jake was very calm. He assessed the kid. He was very calm with the people. Some fat woman was yelling the whole time. You know, it's like, come on. They called an ambulance, and I said to Jake, I said, you know, said he's going to be fine by the time that ambulance gets here. And sure enough, the ambulance got there. They wanted to put him in it, and the mother said, no, he's fine. I don't want him to go. But point being is that you set the tone in the field. So you got to be comfortable with what you're doing. Part of that confidence comes from experience. It comes from doing this stuff. And it's hard to get you access to procedures and things because it's just not enough out there. There's not enough programs open. They get filled up with all this other stuff. And now in the state of Florida, they're going to be doing a higher level of, what do you call it? Certification for nurse practitioners. They're going to have doctorates now so they can dispense narcotics, write for narcotics, write for everything a doctor does. They can write for all the stuff. They don't need doctor supervision anymore. He doesn't sign off on their charts anymore.
Then it's the coverage.
What's the difference
It's the break in coverage.
Well, they're nurses. They go to practitioner school for 2 years. Okay, now they want to make it 3 so they have a doctorate, not just a master's. Most of them have masters. But in order to actually dispense and practice without doctor supervision, you have to have a doctorate. That's 3 years of training. That's clinical training. It's not medical school. It's like the PAs do. You go into a hospital and you train with a physician. You train with the different doctors that do different types of stuff.
Under a certain specialized field.
So it's not the same level. They're not residents.
Well, he's asking what can they do differently
Than a doctor?
Right.
Well, as a nurse practitioner who has her doctorate, she can do everything a primary care doctor would do. Now, she couldn't go do surgery by herself, you know, that kind of stuff.
She doesn't get paid less money and not have to carry the same insurance.
Yeah, I mean, in terms of malpractice, there's less of an issue with it because their limits are different. But, you know, for primary care, that's fine because really she'll be dealing mostly with well patients, immunizations, OBGYN, you know, nurse midwives that for years they've done all that kind of stuff. So I don't see the big deal. Most of the physicians in the state are against it. You know, saying, well, you're going to open the door to this drug abuse that we had that problem with a few years ago with these clinics popping up and you know, handing out 1,000 pills a month to patients. Yeah, maybe, but in this situation, that nurse practitioner is actually, yeah. In this situation, that she's on the hook or he's on the hook for writing those because we don't have that situation right now anymore. That's gone. And you know what's ironic with that, because I see this, it's still going on, but it's not pills this time, is that you get these business people, and I had one contact me about a clinic he had. He's got 2 of them actually, one in Naples, one in Fort Myers. He knows nothing about medicine, but you have these clinics that pop up, they go out, they look for physicians to hire to do the medical stuff, but they run the clinic. They do the billing. They do the advertising. They take the lion's share of the profit off of it. If there's a problem with billing, with Medicare, with the state, Department of Health, ACA, whose ass is on the line? It's the physician's ass, even though he has no control over the administration of that practice, the billing or anything else, his butt is on the line. What do you think happened to all those people that had those pill mills that ran them? I'm not talking about the physicians. We know they prosecuted a dozen of them. What about all the administrators that owned them and ran them? Yeah, they just left. They had nothing happened to them. It was the physicians that got nailed. I want you to think about this fact. I'm always taught, I've always been taught and believe that my medical license is a piece of property. I own that. Nobody has a right to take that from me. By the same token, it's my obligation to make sure that I don't let anybody take it by doing stupid shit. And I say the same to you. You have a paramedic license. Yes, you work under a physician, but you still have that paramedic certificate that entitles you to work in the field. The difference is when it comes to medical personnel, paramedics, nurses, physicians, EMTs, law enforcement people, fire people, you're on call 24/7. I don't care what you do in your off time. You're still on call 24/7. What do I mean by that? If you go out, get drunk, and get in a fight, guess where they're going to go? They're going to come after your permit, your certificate and your license to practice. They're going to come after you as a fire paramedic or as a paramedic or as a fireman EMT, whatever your designation is. And they're going to take that license from you to be punitive. So like it or not, you're on 24/7, and you got to realize that if you're not in your own house drinking a beer, you better not be out there drinking a beer. Because you know if anything's going to happen, it's going to happen in that situation. And you'll end up losing something that you've worked hard to have. I know physicians who, have reached that point where they almost lost their license, and they were on probation, and they weren't able to work for a year, 2 years. What do you do when that's all you know how to do? How do you support your family? How do you pay your bills? Can't work at 7-Eleven.
Good. It's got a different lifestyle.
You have to sell everything you own. But my point being is that it's important to understand, just as an aside, why you need to value what you have. All right, so not to get on a tangent, but anyway, coming back to this standard competencies, you may see more and more of this popping up. It is not the law of the land in Florida at this point. Florida has their own tests that they give. I don't know if 5 years from now it will be. Can't answer that. I haven't spoken with Dr. Nelson in about 1.5 years, so I don't know where their impetus is. All right, so this is just a general principle of this. What are we going to look at? Well, what is neurology really? What is neurology in terms of what we deal with in the field? Because, you can have a humongous expanse of information that's considered neurology, but what do we really deal with on a regular basis? What is our most common kind of call that we get that's neurologic in origin? Right. And I'm not talking about trauma, I'm just talking about general call, and altered mental status is probably the main neurologic thing we see. Very broad term, general term, doesn't point to any particular thing. When I give you a scenario and I tell you the patient's difficult to arouse or is confused, that goes right back to the same thing, altered mental status. Now, when we talk about altered mental status, does that always mean the primary problem is in the brain? No. We know that doesn't, because we even saw with shock today, capnography. We know that other things cause that to happen. Other things that are unrelated to stroke, seizures, epilepsy, and even pain, which is what headache's supposed to be, can cause this altered mental status. And that is a common complaint. How do we deal with it? Is there anything you can do or have at your disposal? You don't carry CAT scanners with you. So what do you do with altered mental status? What are your limitations with altered mental status? Okay, most of it's your history and then what you see physically. And you do have some things you can check. Their vital signs, of course. You can check their glucose. You can check their pulse oxygen capnography. So you do have some things you can check to rule out some of the more common causes. In this series, what they want to talk about specifically is what the competencies are for medics nationally, and it deals with these 10, 9, 10. There's more on the other slide. Presentations. But what I want you to think of is not so much these individual diagnoses, but the overall process of what you do pre-hospital, because you are not going to be able to diagnose a lot of this stuff because you don't have the time and you don't have the tool. Thanks, Jess. Do you want to give this lecture?
No, just going out there with you.
To be able to deal with this. Interestingly, just as a point of reference, and the data, you understand that when we look at data from a textbook, and this even though it was printed in 2013, it's almost 10 years old. It takes that long for data to get into a book, for the book to be written, for the editorials to be done and the editing done of the book, and for it to come out in final form. So the data is always older, but this is probably pretty much still, still pretty true, I think, for the most part. And the statement that's made is that the top 15 causes of death in 2007 were neurologic in nature.